Booker, just checking. Are you trying to play the video?
Yeah, so there's having technical difficulties right now.
Okay, no problem. That's fine.
Sorry, just give me 1 second. I have to run down and just check on my son. Just 1 second. I'm so sorry.
That's fine. You can kill time. Thank you, Dr. Itunu. Booker, is your technical issue surpassed? No? Yes?
Should I start letting people in?
No. No.
Okay.
Well,
Are we
I don't
waiting
know.
till like quarter past?
I'm trying. No, 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 no. We need to start in the next minute. Booker, you okay?
He's
Well,
disappeared.
what's the problem?
I'm trying to understand that. That's a technical issue with the video. He's trying to work it out. I think that
Okay.
Sam has changed something, and I'm not too sure if it's very clear. I think the video is playing on the waiting room. I can also not play the video, and I can just share screen of the flyer that was done for Eventbrite, and we start. 2 seconds. Let me just open it. Let me see if this works. Just so it doesn't look so bad. Would this work, Booker, to start instead of hello?
Hello?
Booker seems to have dropped off the call, hasn't he?
No, no, he's on the call. He's the only one that can start the call. So
Okay.
he's on the
No,
current.
I'm also signed in using the Khan account.
Yeah, he always needs to be. Okay, I spoke to him. We are going live. Okay, I'll just be sharing screen
Tell me
live.
when to start talking.
Yeah, sure. Let's start admitting people in. Booker, can we go live? Okay, perfect. Is he streaming online?
Yeah.
Okay, wonderful. Okay, we're streaming. We're starting in 1, 2, 3, 4, 5. Everybody that was in the waiting room, we just want to welcome you to Health Hour. We're looking forward to have a wonderful session. Thank you for your patience while you waited in the waiting room. I'm just going to pass it to our host, Professor Margaret Ikpo, for the welcome. Thank you.
Thank you, Natasha, and welcome everybody to this Saturday's Health Hour with the Caribbean and African Health Network. Apologies again for the late start. We've just had a minor technical issue. My name's Margaret Ikpo. I'm a GP based in Hull, but I'm also the Vice President for the Royal College of GPs. And it gives me great pleasure to introduce this session today. I'm currently in Cambridge. I don't live in Cambridge, but it's sunny here. If you want to just drop us a message in the chat so we know where you're all dialing in from, whether that's locally, nationally, or even internationally, as I do know we have some international people that join us. So Dr. Itunu Johnson-Sogbetun is, I mean, I don't know where to start. She's absolutely an amazing women's health guru. If I read out her bio, we will be here for an hour, seriously. She has over a decade of experience in women's health issues and then some. So without further ado, because I'm mindful of time, please feel free to drop any questions for us in the chat so I can collate them all once her presentation is over. If you have heard her before, you'll know what a treat you're all absolutely in for. So over to you without much hesitation, Itunu.
Thank you so much for that warm introduction. It's just such an honor to be in this session hosted by one of my sheroes, the absolutely amazing Prof. Margaret Ippo. So I'm delighted to be talking about this issue today because it's something that has a lot of resonance for me professionally and personally. So just let me know if you can see my screen. Great, thank you so much. So let's get into it because we don't have that much time and I really want us to be able to get questions in and really have a great discussion around this topic. So Dr. Prof. Ikpo has already said about who I am. I think the most important thing about this slide is to say that I combine personal insight with professional expertise. And that's because I myself have gone through sort of health issues, and I'll talk to you about my experience with PCOS shortly before we break it down further. So why is this important? So PCOS, we know affects around 1 in 8 women in the UK. That's how common it is. But many people don't even know what it is. And you know, very soon we may have a name change because it's such a misnomer. What does PCOS stand for? Polycystic Ovarian Syndrome. But actually, this is a condition that is a whole body experience and has physical health and mental health ramifications. So it's not just a reproductive health issue, as the name suggests. And in fact, there are people who have polycystic ovarian syndrome who don't have polycystic ovaries, which makes it even more complicated. So yeah, the name is not a good name because it's confusing. And so we're in the process of trying to figure out a new name. So watch this space. But what are the implications for Black women? And we're going to talk about this a lot more, but actually for our Black experience means that we can often face long delays before getting diagnosed. And there's often years of frustration and emotional distress. And there's stereotypes and misconceptions, which mean that symptoms are dismissed or overlooked. And health inequalities. And, you know, this is one thing that Khan is so passionate about trying to dislodge. And we all who work in this space, we want to make it such that everyone can get the proper care that they need. But we know that Black people often struggle with getting the care that they need. Right. So what's my story? So I live with PCOS. I was diagnosed in my 20s with PCOS. And it's been a personal and very challenging journey. So the first thing that happened was back when I was 27, and some of you who've heard me speak will know that I share that I was diagnosed with hypertension at the age of 27. At that time, my blood pressure was really high. So we're talking around 190 over 110. I could have had a stroke. I could have, you know, all sorts of horrible things could have happened. But thankfully, I was a doctor. I realized I had headaches and I went and had got my blood pressure checked. But at that time, they did lots of tests for young people's, why do young people get hypertension? But no one at that time linked it to my polycystic ovarian syndrome. Shortly after that, I started, you know, I had a fertility struggle that ended up lasting 4 years. And during that, one of the things that was brought up was my PCOS. Eventually, I ended up having IVF treatment. Sadly, the first pregnancy that I had was a twin pregnancy that I lost at 22 weeks. And obviously, that was very devastating. But I'm very blessed that I now have my 7-year-old son, who was born thanks to such amazing, culturally competent care that I received. But of course, we know that many of these experiences that I've had are linked in with PCOS. So infertility, one of them, having challenges during pregnancy, and those sorts of things, and miscarriage. Now, PCOS has not just affected my physical health, it's also affected my mental health. And I've had struggles with depression, with relating, to a lot of the health issues that I've experienced, but also related to the PCOS, you're more likely to struggle with depression. And then the most sort of shocking thing that happened was, at the age of just 35, so this was some years ago, I noted that I just had a little bit of spotting in between my periods. I was still having regular periods. My periods were sort of heavy, but nothing that that was out of the ordinary for me. And I just had a bit of spotting. In fact, I did the wrong thing and I just kind of ignored it, thinking it was just going to settle. So I probably noticed this in about April of that year, but I didn't go to get checked in October. And imagine my shock when I was told that I had pre-endometrial cancer at the age of 35. And this again is very much linked with PCOS. So I've had so many of the complications of PCOS, and a lot of that has happened to me because it's more likely to happen because I am Black, because I'm a Black woman. So our Black and brown experiences with PCOS tend to be worse, but every woman's experience is different and no two journeys are the same. And so PCOS doesn't always look the way people expect, and that's why we need to be knowledgeable. We need to know what the symptoms are and how to diagnose it. So I'm going to go into a case study. So meet Katisha. She's Black British. She's had irregular periods since she was a teenager. She was told it was normal. She also had struggled with weight gain, excess hair, acne, and this was dismissed. She was just told lose weight by eating less and moving more. Just do that. And nothing was really done for her excess hair and acne. And the acne was causing her issues because she was getting hyperpigmentation and she was getting hair around her chin, which was causing sort of embarrassment. But when she tried to go to the doctor, it was kind of she was just dismissed. Then finally, she was struggling to conceive. And after trying for about 2 years, she was finally referred, and she was referred to the fertility clinic, investigated. And that was when the diagnosis of PCOS was made. So she had gone through years of stress, symptoms not taking seriously. And then later on, she had fertility support, but that diagnosis came late for her. And I think this is important. Because you don't know how long it's going to take for your fertility journey. And of course, today's not about fertility, but we know that for Black women, our fertility does start to decline quite steadily in the mid to late 30s. And this has implications because if you know earlier, then you can actually make plans. It doesn't mean you need to rush thinking about fertility, but you can plan. You can have an idea of, okay, how do I figure out what next steps are? Because sometimes people try it and it's then so late, and that makes it less likely that they're actually able to achieve a positive outcome with the fertility treatment. Okay, now we've got Clara. She's slim, she's active, she looked healthy, but she suffered with fatigue, irregular cycles. She was getting hair thinning, particularly on the top. No one thought thought about PCOS because she didn't fit the typical image. But eventually she persisted and she had blood tests, an ultrasound, and of course, with her symptoms, it confirmed polycystic ovarian syndrome, and she was given a diagnosis. She was relieved, but there was a lot of misconceptions. She's like, what does PCOS look like for me? You know, a lot of the information she was seeing was around sort of women struggling with their weights and things like that, but she had a very different experience of PCOS. So what is PCOS? So as I say, the name is in itself a misnomer because polycystic ovarian syndrome, which is what PCOS stands for, seems to suggest that this is a reproductive issue, and you know that you have to have polycystic ovarian morphology on scans so to be diagnosed with PCOS, but actually it's around hormonal imbalance, and it's linked to higher levels of male hormones known as androgens and insulin resistance. And so it's quite a complicated condition that has metabolic ramifications. So we'll talk about some of the complications in a minute, but it's not just a reproductive issue, and that's the important thing. You know, I've got PCOS, I've had hypertension, I've been diagnosed with prediabetes, I have raised cholesterol. All these metabolic syndromes are linked to PCOS. So it's not just about reproduction. Now, how do we diagnose it? So we diagnose it traditionally based on 2 out of 3 of these criteria. So one of them is a woman having irregular or mixed or missed periods. So women will say, I've gone 2 to 3 months, 4, 5 months with no period. High androgens, and that's based on symptoms or blood tests showing the levels of high androgens. So those symptoms we refer to as, it's like acne, excess hair in places that you don't normally see hair in a woman. So like on the chin or the chest. And you know, that's something we call hirsutism. And these, you know, hair thinning, these issues are signs of high androgens, and they are associated, you know, they're part of the diagnostic criteria. And the final criteria is polycystic ovaries on a scan, but as you can see, it's 2 out of 3. You don't have to have polycystic ovaries on the scan to be diagnosed with polycystic ovarian syndrome. And as I mentioned at the very start, the name will change soon, and I think that will be helpful to help us as professionals and as patients really understand that this is a complex condition. Now, what are the common symptoms? I've already spoken about some of them. So they're the gynecological symptoms with irregular periods, women get heavy bleeding, you know, in infertility struggles. But then there's the sort of skin health symptoms, so the acne or the facial male pattern hair growth, the hair thinning, the acanthosis nigricans, which is sort of hyperpigmentation and dark skin patches, skin tags. And then there are the physical health symptoms that women have, so things like fatigue, weight gain. But then there's also the mental health symptoms, so things like depression, anxiety, mood swings. And you know, one of the things to recognize is that not every woman with PCOS has all the symptoms, and severity varies. And we find that Black and brown women, so Asian and Black women, tend to have worse symptoms of PCOS. Now, what are the complications? This is really important because it has really big ramifications for our health. Type 2 diabetes related to insulin resistance, high blood pressure and cholesterol. And as I've mentioned, these are things that me, Itunu, with PCOS, not as a doctor, I've experienced with pre-diabetes. I live with high blood pressure and I have raised cholesterol. These are things that I'm trying to manage. So it's not, you know, it's not just something that happens out there. These are real complications. Sleep apnea. So again, especially with weight gain, and of course, sleep apnea is one of the most awful conditions that can accelerate. So it will make diabetes worse. It will make high blood pressure worse. It will make cholesterol worse. It will make the risk of heart disease and strokes worse. And so sleep apnea is quite commonly linked. And of course, we don't think about it. We don't ask about it. And this has a real ramification on our health. And then higher risk of womb cancer. I just shared my story at 35, but I've seen even younger women with pre-endometrial cancer or endometrial cancer changes who haven't had periods for a long time. And, that has then led them to develop endometrial thickening, which is the womb lining thickening, and womb cancer. So Black women are already at higher risk of womb cancer. If you're overweight, you're already at higher risk of womb cancer. And if you've got PCOS, that risk is even more heightened. So this is really important. And it's also why, if you haven't had a period for more than 3 months, don't sit there. Go and see a doctor, because it is not healthy to not have a period for more than 3 months, because you need to bleed, and that bleed needs to be induced. If you're not bleeding, to reduce that risk of womb cancer. And we talked about the mental health challenges like anxiety or depression, and the fertility difficulties that women have with PCOS. Now, as I've mentioned, Black women with PCOS are more likely to have weight gain, high blood pressure, and type 2 diabetes, and also high cholesterol, triglycerides, and BMI, really struggling with that weight. Already, Black women are the most likely to be overweight in this country. And so if we are overweight, it's nearly double the rate of metabolic syndrome. And that's that awful trio of high blood pressure, high cholesterol, type 2 diabetes with insulin resistance. And this increases risks of things like heart attacks, strokes, all these cardiovascular health problems and vascular health problems. Now, of course, fertility struggles, as I mentioned, miscarriage are also more common. I've shared my story. Unwanted facial hair can cause distress. And of course, many hair removal methods have not been formulated for Black skin. And in fact, many hair removal methods are not even available on the NHS at all. So people are often in the hands of charlatans, marketing all sorts of things on social media to try and help desperate women struggling with unwanted facial hair and acne. And the people who are providing good care often is very expensive and out of reach. And so it can be very devastating for women to have these marks, whether it's from acne or from unwanted facial hair. And that has an emotional toll, which can worsen already existing depression or anxiety or low self-esteem that can be associated with PCOS. As I'm sitting here having this conversation with you, I want you to think about what it's like. If you've had that experience yourself, or other women, young women, having these experiences, and think about the ramifications, particularly if they're sort of, in their early 20s, late 20s, trying to navigate life. And this is really making it difficult for them. And so PCOS can have a greater impact on quality of life for Black women. And that's a really important point. So it's not just about the physical health and the mental health ramifications. There's also quality of life implications as well. So what is the patient experience? I already talked about long delays before being taken seriously, things, either dismissed as normal or it's just because you're overweight. Go and lose weight, eat less, move more. And that's almost kind of like a feeling of medical gaslighting, because often these women are trying. They are trying to lose weight. They're trying to eat less and move more, but the tables are stacked against them, because it's incredibly difficult when you've got insulin resistance, you've got all these other challenges with low mood or anxiety, stress, and other things in your life. So, we talk about the biopsychosocial. So when you've got PCOS, you've got this biological condition, but there's psychological implications, and there's also social factors. We know that there's that pressure is existing as a Black person in a space that wasn't necessarily created for you. But on top of that, many of us, will be, having other pressures. We talk about the immigrant tax, supporting other family members in the Caribbean or in Africa, the pressures of, relationship pressures. Some people might be single moms, some people might be supporting elderly relatives, as well as working full-time, as well as supporting young children. There's all this other stuff going on. And so again, we have to look at the big picture. The patient experience can be very, very challenging. And then there's frustration, with not being given clear answers. Maybe some doctors are not so clear on the condition. And then relief when finally getting a diagnosis. But then sometimes there's no next steps given, and it's almost like people are just left, in the ether, not knowing what next to do. And then stigma and misconceptions make the journey harder. So what is the management? Firstly, it needs to be personalized, because there's no one-size-fits-all treatment. And we need clearer guidelines to direct how we manage. So lifestyle is important. Of course it is. It's foundational. Just even 5% weight loss can help improve symptoms. But how do we get there? We have to be able to support people to have that balanced diet, to get that physical activity. So I talk about not putting pressure on women, Think, how can we link this into your life? So is it that you get off one bus stop and walk the rest of the way to work? Do you dance with your children? I know people who just put on, whether it's Afrobeats or, whatever, and then just dance with the children, and that's how they get their exercise. Or you go for a dance class, stuff that you enjoy, you tie in movement with joy. But again, even with all of this, sometimes it's still not working. And of course, there are new medications that can help with weight management, but we still don't have all the research to know how effective they are in PCOS. But certainly some endocrinologists, some women's health doctors that manage PCOS are suggesting these treatments to try and help women. But again, a lot of the time it's out of reach, because again, private, because a lot of this stuff is not available on the NHS. Now, if you are not having a regular cycle, and I need to say this very, very clearly, you need to have a bleed at least once every 3 months. If that's not happening naturally, you need to either go on a pill to help regulate your cycle, or you can have progesterone to induce a withdrawal bleed if you haven't bled in 3 months. And this is to reduce the risk of womb cancer. This is so, so important. Now, of course, fertility treatments, we've had conversations about fertility, like ovulation induction or IVF may help, and this may be necessary. And I suggest that if you have PCOS and you're struggling with fertility, go and reach your GP and try and make sure that you start that process earlier rather than later if you can, if you really want to, because that would improve your chances. And of course, how to manage acne. So some of the hormonal treatments can help with managing acne and excess hair and hair loss. There are other treatments as well that can help with that. So anti-androgen medications. But again, we don't have as much evidence as we would like, but we do try these medications. And amazingly, there's now a new anti-androgen progesterone only pill, because prior to this, we only had anti-androgen progesterones in combination with a combined pill, but not everyone can have a combined pill. So we now have more options. And so, we can provide women with more options. And of course, supporting your mental health is so important. Therapy might be helpful, support groups, all of these things are very, very necessary. Now, we've talked about some of these challenges, repeated disappointments, uncertainty, laser treatments not being designed for darker skin, people going to people who don't know how to treat our skin. And, it can be really frustrating. And there's something that I always talk about, which I think is really important, because we have a lot of fear around hormones. And that's for understandable reasons. Past medical, so something I call hormonophobia. So past medical abuses have happened creating lasting mistrust. And of course, people may have tried hormonal treatment and had untoward side effects. And it's been approached that, oh, this is all you can have, and there hasn't been a real conversation. And of course, they don't feel like they trust it, and, a lot of the treatments didn't feel, it feels unsafe or it feels unnatural. And of course, some cultural and religious beliefs view hormonal treatment as not right. But again, some of this is based on lack of understanding. As I've explained, if you're not having a bleed and you're just letting it ride, that's very dangerous for your womb lining. And so the only thing we can do to induce that bleed is, at the moment, hormonal treatment. Of course, we can do lifestyle stuff, but that might take a long time to work. If you're trying to, lose weight and move, of course, those things may help with getting your bleeds back, but often it can take time to work. And we can't leave you for 6, 9, 12 months with no period, because that can impact your womb lining. So again, we have to have these conversations. We have so many different options of hormonal treatment. We can find the right one for you, but it's about conversation. And of course, there's been limited research, not enough studies included Black women. So there's a lot of confidence in whether it's actually safe for us. And this is something that we're working on, we're talking about. But it's about, how do you have that conversation? I always say it's a meeting of two experts. You are the expert in your own body, and we are the experts in the medical information. But you need to educate yourself from reliable sources, not TikTok. Yeah? Of course, there's some doctors that are giving good information on TikTok, but TikTok is full of people who say, oh, we can help you with your PCOS. Just pay for our 6-month course. We have this supplement. It's so good. And you don't know what you're putting in your body, but you need to speak to people who are specialists, who are experts, who are professionals, to get accurate information or read accurate sources, so that you're not being hoodwinked. Because of course, this is very frustrating and emotive. I can understand. I nearly got hoodwinked myself, when I was struggling with my fertility journey. I almost literally had someone drill my ovaries, which wasn't necessary, but I was so desperate. So I can understand. And I'm a doctor, I'm a women's health doctor. So I can really understand, but we need to be able to face the facts of what is truth, right? And hormonal treatments can be very effective to tailor and improve your quality of life with PCOS, but it's not the only choice. Don't make it seem like, oh, Dr. Itunu is saying, oh, no. There are other options of treatment, but it's an important choice. And it's really, really important, particularly if your womb lining, if you're not bleeding regularly. We don't want you to get thickened womb lining and endometrial cancer. So it's really important that you seek culturally competent care from a doctor who's going to address your concerns, who's not going to push their own agenda. I'm really not about trying to push an agenda. I want what's best for you, and I want to work with you for what's best with your body. So it's about opening the dialogue, sharing your worries with your doctor to gain clarity and build trust. And of course, community support as well, because we can't do it alone. We weren't designed to do it alone. So what can you do? You can track your symptoms, know what's happening. So then you can have information, you've got evidence to take to your doctor. If you've gone to your doctor and you don't feel that you've been heard, get a second opinion, even a third opinion. When you're talking, talk about side effects that you might have had. What is really important to you? Is it fertility? Is it the acne? Is it the hirsutism? Is it the depression? What are the things that are really impacting you? But also, what past experiences are making this worse? Make sure that your treatment plan considers who you are, your skin tone, your hair type, your cultural context. And if you feel rushed, ask for another appointment or a longer appointment. See another doctor if you feel, again, as I said before. So we're coming to the end of the conversation. There's no shame in needing hormonal or fertility treatment. It's about health, not weakness, right? Talk to others with PCOS. I've shared my story with you today, because it's important that you realize that you're not alone if you have PCOS. Look for trusted voices. There's charities like Verity PCOS, who I work with very closely, who provide really amazing information, support groups, advocacy for patients. And we've literally just completed the process of getting the 10 top research priorities for PCOS research, which is amazing. We've got and this will be co-produced with professionals, patients, with charity members, everybody who has a vested interest in this. So we want the questions that we need answered to know how to best look after PCOS. Okay, so remember, you're not alone in this. Please be kind to yourselves. Your journey with PCOS is valid and your voice matters. So in summary, you know, PCOS affects millions and it impacts every part of our lives. You know, delays, stigma, and health inequalities remain a big challenge for Black women. No two women's experiences are the same, but together we can shape a fairer, faster, more supportive future for Black women with PCOS. So time for questions. You're muted. You're muted. Prof, you're muted.
Can you hear me now?
Yes.
I'm so sorry. I was saying wow and frantically trying to unmute myself. Itunu, that was just brilliant. I mean, I could have listened to you all day long. First, I just want to thank you for sharing your own personal story and driving home the salient points of what it means as a Black woman to have PCOS. We have about 20 odd minutes. We may go over a little bit, 5 minutes more, because I want to get through a whole host of questions, if that's okay with you.
Absolutely.
So the first is a bit of a two-in-one. So there was a lot of chatter about awareness. So I'm mindful that even some of my own GP colleagues, if you get a report back from an ultrasound scan and there is no polycystic ovaries on the scan, automatically they'll say you don't have PCOS. So even understanding what the syndrome is within the healthcare profession is really, really challenging. So how do you, and you were able to advocate for yourself, and I'm so glad that you had a positive outcome with your son. But if you haven't come from a medical background and then you encounter a healthcare professional who's just going to use an ultrasound scan report as a means of diagnosis, what would you advise us to do within GPs and also for the lay individual who's trying to be heard?
So I think this is the reason why we need very good guidelines. So at the moment, we've got patchy guidelines. And so we are hoping that very soon, there's some amazing international guidelines, but it's local, sort of UK-based nice guidelines that we're hoping that they're going to adopt the international guidelines. And so we need to disseminate this information widely around GPs. And we're hoping that the name change will also help change the focus. Because at the moment, because the name is PCO in the name, it makes and confuses doctors and patients. And so that's why it's been very important to say we actually need a more inclusive name to stop confusing people. But how can we, as patients, going to see a doctor who may not know, and they may not even know what they don't know, right? And this is the challenge. So this is the thing. I will always say take information. So there's really good quality information by charities like Verity PCOS. Well-being of women have some really good information. There's really, so take information, share it with the GP and say, I know that there are, say, I know that there are 3 criteria, and if you only need to meet 2 out of the 3.
Okay.
So I'm having irregular periods and male hormone shifts. I believe that I can be diagnosed with PCOS. Advocate for yourself. Of course, that puts a lot of pressure on the patient, and I'm sorry that that's still going on at the moment. But hopefully, we're trying to do work. We are trying to do work to educate our colleagues. We have now a new women's health SIG in the college, and we're going to be doing a lot of work to try and update GPs on new things that have gone on in women's health more generally, because it's not just about the GPs who know about women's health. We want all GPs to have some updated basic knowledge that they can use. So we're working on it from lots of different angles, the DFSRH, the RCOG, we're all going to be working on it to make sure that we improve general knowledge.
And coming to that knowledge, please, we're both in the college, so we need to really drive this forward. So after this meeting, we need another meeting. So
yeah.
Coming to the new name, any heads up on what this new name might be at all?
I've been told some things in secret, but I'm not allowed.
I
I'm not
can't pay
allowed.
you. Can't bribe you. Okay, all right.
I'm not allowed.
Okay, all right. Don't worry. Look, Shebi, I'm seeing you this evening, so don't worry. Okay. Now on a really kind of serious matter, there was some real resonance with your story, and someone's asked about fertility support. So you mentioned you got some culturally competent care which allowed you to get a diagnosis. But if you're struggling to get that support within the NHS, are there any other avenues? I know you mentioned Verity as well. That's why I muted myself because I was trying to find the link. If anyone from Khan can find the link and put it in the chat for us. But what can you do if you're really not finding that support within the NHS structure?
So it's really hard. I was very lucky. Why was I lucky? My parents could afford to buy a flat in Islington. And so because I had that Islington address and I had an Islington GP, I was able to get fertility treatment and on the NHS. And even when I lost the first pregnancy, I was allowed a second cycle. Depending on where you live, is a postcode lottery, which is awful. Absolutely awful. And because I was in Islington, I was able to have a really good team in a very good hospital, right? So, but the thing about it is you need to try and work with what you've got.
Yeah.
You know, if you're struggling, you know, to get the right care, so you can look and see, you know, what are my entitlements within the NHS. So often each ICB will have the fertility requirements and eligibility and what is available. So at least make sure that you know what you are entitled to. And hopefully your GP can advocate for you as well. But if you haven't been able to get, then you need to think about the private sector. And it's so expensive.
It is, yeah, it is.
Very expensive. And, you know, there's amazing Dr. Eddie, who he and his wife speak on Khan. He has a fertility clinic. It's based up north, but he's you know, someone that I can definitely recommend as someone who can be really really helpful. But the thing about it is, you know, a lot of this stuff is expensive. So sometimes you may be able to pay in installments, but be careful where you go. Because sometimes if it's so cheap, it's because it's nonsense they're offering you. And so that's where the balance is. But you can also go abroad. Some people go to, because in countries like Nigeria or Ghana or Cyprus, there's other countries that they have really good fertility treatment. So like say, for example, Dr. Eddie has a clinic in Lagos as well, where he does the fertility treatments. So sometimes some people go abroad because it's cheaper abroad than it is here in the UK. But again, you have to do your research because there's so many charlatans out there. You know, you can really get into trouble by going to the wrong place. So get a second opinion, get reviews, make sure you know who you're dealing with before you put a penny down.
Okay. Just very quickly, back to the diagnosis. Sorry, I'm going all over the place. Someone's asked, what if you only have polycystic ovaries, but not many of the other symptoms?
Then probably you don't have polycystic ovarian syndrome.
Just wanted to clarify that. Thank
So
you.
you don't have polycystic ovarian syndrome. Now, you may develop some of the other symptoms in the future. Many young women have polycystic ovaries. So that's why we don't like to diagnose before the age of 24. If I have a 16-year-old and I do a scan, she's likely to have polycystic ovaries, but she may not have polycystic ovarian syndrome, but she might.
Yeah.
Right? Yeah. So we need to see what happens. But, you know, you can have polycystic ovaries and not have polycystic ovarian syndrome.
Okay. Then this is a really good question. So Farouz has asked about BMI guidance and the different body compositions across ethnic groups. Now, I know when I refer a woman to a fertility clinic on the NHS, they use the BMI, their BMI as a point of reference for excluding someone if it's over 30 in my area. So does that mean that some individuals are classified as overweight when they might actually be healthy?
This one is a big question because what are we benchmarking on, right? A lot of the evidence, even this whole BMI stuff, it was just dreamt of by somebody. And it's benchmarked on a Caucasian body type, right? We don't really know. Somebody in America has tried to work on what is a healthy way of assessing women's body compositions or black women's body compositions, but we don't really have an strong evidence base for how we address or assess a black woman's body composition. Because firstly, our muscle structure can be different, right? Where we put on the weight can be different. But what we see though is that if we're even using the BMI, at a lower BMI, Black people are more likely to get the ramifications of being overweight. So say, for example, if your BMI is 27 as a Black person, or a brown person or an Asian person, you're more likely to have things like hypertension and prediabetes and cholesterol problems than if you were white and your BMI was 27.
Yeah.
But we still know that it's an issue with how we calculate these things. So I don't have a clear answer for it because more research needs to be done for sure.
Okay.
And unfortunately, there's discrimination against women and Black women because sometimes it's really, really difficult to lose that weight. But the NHS has to have some kind of criteria.
Yeah.
So it's tricky. It's really tricky.
And just a quick plea from me, because you did mention the lack of Black women being involved in studies, PCOS studies. So actually, if we don't get involved with these studies, then, all these results that they come out with aren't actually reflective of our own communities. So hopefully I can do something with Khan in terms of research inclusion later on.
Absolutely.
Thank you. Coming back to the weight loss, because I really want to come back only for my own personal interests, but no, others as well. Natasha has asked in the chat what symptoms people are struggling with, and the weight loss seems to come out number one. So what are your thoughts? Someone's asked, what are your thoughts on weight loss surgery? But I'll also add to that, what are your thoughts on these GLP-1 agonists, so your Mounjaros and such? Because at the moment, PCOS is not on the list of conditions that someone can ask Mounjaro for. So thoughts on weight loss surgery and injectables?
Now, of course, if a woman has a high enough BMI that she qualifies for bariatric surgery, whether or not it's contributed to by PCOS, then that's a conversation around, bariatric surgery, the benefits and the risks. We know about all the obesity-related health conditions. And of course, if you have PCOS, that's heightened because you already have PCOS-related health conditions. So things like obstructive sleep apnea, diabetes, I mentioned all of them. But the issue is, bariatric surgery can be helpful, right? In a similar way, so if, say, for your BMI is over 40, because, you have to weigh the risks and the benefits. In a similar way, GLP-1 agonists, if I'm being honest, I've gone on it myself.
Mommy.
When I was diagnosed with pre-diabetes. I'm so sorry. I'm really sorry. That was
no, this is
I'm sorry. So GLP-1 agonist, as I say, my endocrinologist suggested it with my pre-diabetes, and I've gone on it myself. And actually,
my teacher's getting annoyed. I need to be in a more lighter place because she can't see me because I'm too dark. So please.
Just a minute, okay? I'm coming. So 85. So I went down from 85 kilos to 66 kilos.
Oh wow. Well done.
On the GLP-1s.
Wow.
And so that was amazing. So my pre-diabetes is reversed. My cholesterol is coming nicely down. I had to do it because I don't want endometrial cancer. I don't want diabetes, right? And I was trying other things and I was struggling to lose weight. So it's not like I'm not a believer. The problem is what happens after. So whether it's bariatric surgery or GLP-1s, we still need to change our lifestyle.
Yeah,
it's still fundamental.
That wraparound support, yeah.
And then it's not only that, it's this as well, the psychology. Because for many of us, even though we've got PCOS, so it makes it worse. But when we were young, you are happy. Here's pounded yam, or rice and peas and chicken and oxtail.
Yes.
You are sad. Here is a dumpling.
Mhm.
And so we develop that
Emotional eating.
emotional eating. So
Mhm.
what tends to happen when we follow people up, whether it's bariatric surgery or GLP-1s, is that if you stop, you often gain the weight back if you have not dealt with some of the underlying condition. So it can help you to begin to get rid of a lot of the weight, to do the work, but you still need to put in the lifestyle things in place. And with GLP-1s, you might need to be on it for the long term in a similar way as you would be on a hypertension medication or a diabetes medication. You don't say, oh, my blood pressure is under control, I'm going to just stop. So similarly, we may need to think about that, but the evidence is not, we don't have, evidence for the use of GLP-1s in polycystic ovarian syndrome. We're borrowing some of this from its use in diabetes. We're borrowing some of this from its use in weight management, but we need clearer research.
Yes, we do. Yeah, there's a lot of research out there. I mean, there's early research that it's beneficial in even endometriosis.
Yeah.
Even with alcohol, some of my patients who were addicted to alcohol have asked to stay on it. So, but that's a whole nother story. I'm going off on a tangent. I'm mindful that your son needs his mummy right now. So I'm going to ask you one more question. I've learned a new word today, hormonophobia. I didn't know that word existed. Someone has asked, okay, what about going herbal, please? Is there anything herbally that we can take?
Okay, so herbal. This is a good question. One, because I think it's important that we understand what are the natural things that we can do. Because a lot of our community, it's important. And we can't say, oh, it's important. We need to be thinking, what are the things? Unfortunately, there really isn't any strong evidence for any of the sort of herbal treatments and natural supplements. Just give me 5 minutes, okay? 5 minutes. Sorry. For any of the herbal or supplements that are available, probably the one that I sometimes say you can try is myo-inositol. And you can try it for 3 to 6 months. If it doesn't work, then just stop. So that's probably the one that I speak to patients that they can try. It's worth a try because some patients see it, try it, and then they get a restoration of their periods. They feel better. They feel like their symptoms are improved. But if you go on TikTok or YouTube, you will find a whole list. But again, the challenge is we don't have up to scratch evidence. So more research is needed. And I think this is important for our community because people want to know.
Yeah.
So the general things still apply. What we're eating in terms of a wide variety of fruits and vegetables, high quality, low glycemic, high quality carbohydrates, high quality protein, so and a variety of fruits and veg is still the best way, and portion control is still the best way to try and heal our bodies naturally with good quality food.
Okay, that's great. If you've got time before you go, can you just put the spelling of that product in the chat so people can refer to it later? So we've come to 4 minutes to 12, and I'm mindful that your son has been so patient with us. So please apologize on our behalf, or we needed his mummy.
I'm sorry, his dad went out. He was supposed to be here, but he had to go to an emergency. I'm so sorry, everyone. I literally didn't. It was supposed to be, but you know how it is. I'm really sorry.
Don't worry. I'm sorry we couldn't get to everybody's questions. I feel like we need a part 2 to this. So we'll, once we've got a new name, perhaps that's another time for us to come back in a few months' time to do this. So thank you so much, Itunu, for your time. I'm going to just wrap up very quickly. 3 main points for me. Don't be afraid. Don't be afraid of your hormones. Don't be afraid of advocating for yourself, guys, because the complications are serious if we ignore them. If you haven't had a period for 3 months, don't sit there. Do something, please. And if you can move, if you can, if you can't walk, then sit and do something in your chair. If you can run, if you can dance with the people around you, let's just get moving. And most of all, educate yourself. Let's educate ourselves, because that's the only way we can be better informed. Me, I like TikTok. Itunu, if you're on TikTok, I'll follow you on TikTok. So that's what we'll do.
Lots of great doctors on TikTok. I mean, Aziza is on TikTok.
So we'll see you. I'm going to hand over to Trish. Don't forget to turn your clocks back, guys, tonight, because we don't want you to miss out on next Saturday's session as well. So thank you very much for having us today. Over to you, Trish.
Thank you.
Thank you so much, Dr. Itunu and Professor Margaret. This has really been an insightful session today. So I'm just going to share my screen shortly. Please bear with me. Okay. Kindly let me know if you can see my screen. Can you all see it? That's great. Thanks. So thank you to everyone who attended today's session on the Health Hour. I hope that it really helped you and you found a lot of the discussions that we had today useful. So next week, we have our next Health Hour, which is on early pregnancy, what every woman should know. Please feel free to scan the QR code and share with your friends or anyone that would be interested in the webinar. Wait a second. Yeah, and then we have our Black History Month. So, October this month was Black History Month. So we have two resources, the Black Leaders Toolkit and then the Greater Manchester Event Calendar. So if you want to know more about it, please feel free to scan the QR code whilst you see it on your screen and learn more about what we're doing this Black History Month. And today is our pink party. I was supposed to wear pink, but I think this can still pass for something. Yeah, so today's our pink party. It's happening at Gorton. I believe the location has been changed now, but yeah, I think the details would be in the chat. So feel free to contact Sakinat and yeah, just visit Gorton. It's still early hours in the day, so you can pass by if you're in the area. And yeah, just to show your support for breast cancer awareness. Yeah, and then we also have the Let's Talk Women's Health. So this is about taking control of your health. We have 3 workshops this year to understand gynae health. So if you're interested, again, please scan the QR code on your screen or contact Sakinat at can.org.uk to just register your interest. We have our Green and Arts service. So that's at Bolton every Wednesday and at Stockport every Tuesday. If you're interested in joining fun activities and African-inspired activities as well, please feel free to contact Lola at Green and Arts Wellbeing at can.org.uk or call the number you see on your screen or scan the QR code. Yep, and we also have our Black Health Improvement Program, so that is BHIP, where they offer CPD accredited sessions, support helpline, ongoing engagement, and practical tools to create inclusive care. If you're interested in the BHIP sessions or the BHIP training, actually, please feel free to screenshot any of the any of the slides that I'm sharing on my screen, or scan the QR code for more information. So thank you all for joining us today, and we hope to see you next week. Let me stop sharing my screen now. Okay, thank you all for joining us today. Thank you. Enjoy the rest of your weekend.
And that's our time for today. Whether you joined us on Zoom, Facebook, LinkedIn, or YouTube, thank you for making the Health Hour part of your Saturday. We hope today's session gave you the right dose of health wisdom that you can share with your friends and family. When we share knowledge, we strengthen our entire community. Mark your calendar. Next Saturday, same time. Got a topic in mind? We want to hear from you at health@can.org.uk. Health Hour, hosted by the Caribbean and African Health Network.